Ladies and gentlemen, welcome to the Dr. Joe Show.
Yay!
That's us.
That's us.
That's us.
That was really great, Mark. And are you at home or in your office?
I'm at home, and I just realized since we were having such a healthy conversation, I forgot to go live on Facebook, so I'm doing that right now. Yes, I am in my home, buddy. This is my home domain you're looking at right now.
That's right, and that's what this is about. And Tom,
hello.
Where are you at now?
I'm at the studio.
You are.
Yep.
And is this going to be the last night that you're going to call in?
No. Who are we kidding? I gotta be here.
Okay.
Yeah.
All right. And let me introduce to everybody Lisa Volpe, who is an attorney from New York City, you're there on Long Island right now, is that right?
I am. I live on Long Island. Yeah, and I work there as well.
And I'm so grateful that you are here to really talk about some of the ramifications that we have not really addressed about COVID and coronavirus. And we should be joined relatively soon. I'm just getting a text from her, from Dr. Ann, who is going to be calling in from Austin, Texas, who is also on the front line. So it's going to be a really great show. And I want people to be prepared. This is going to go into places where most people don't talk about. They don't always talk about some of the darker side. We talk about the anger, the stress, the anxiety, the depression. But there are some other ramifications of COVID-19 that are powerful. And here's Dr. Ann coming in. And who is that?
Hey, Joe.
How are ya?
I'm good. How are you?
Great. We are live on WATD. Dr. Ann, let me reintroduce you to Mark, my co-host, and Tom, my other co-host.
Hello.
And up there is Lisa Volpe, an attorney from New York City. And we are just getting started, so welcome.
It's an amazing view you have, Ann.
Oh, thank you. We just had a huge storm here, so I thought that was kind of cool.
It looks very
cool. In our neighbor's yard. Wait, Joe, hang on one second. I'm going to shout to my kid. Hang on one second.
Okay.
Ben, could you bring that picture of me, my Zoom picture? Because Joe.
Yay! Good. Yes, so people understand, Dr. Ann was also one of the early Zoom kids. Which season were you?
Right after you.
Yeah.
2, I guess, right?
Season 2.
Yeah.
So we go way back. It's really fun. And full disclosure, Lisa and I, look at that.
Oh, wow. That's a great picture.
That is a great picture.
It's the same O as Joe's.
Yep, that's right. That's the Zoom logo. I love that. That's a beautiful picture.
Same picture. Look, I never even got it framed. It's literally from the back of the WGBH wall.
Yeah. me too.
Yeah,
Same
totally.
thing, right off the wall. Right off the wall.
Hilarious. Yeah.
That's right. Okay, so I'm going to
photographer.
put this here. Great, and you just leave yours there too. It's great. Love it.
How funny. Thank you, honey.
So let me just ask Lisa first. So Lisa, if you wouldn't mind, can you tell us a little bit about your background in the legal system and what you've been doing for folks there in New York?
Sure. I am an advocate for people with mental disabilities, people who are in psychiatric hospitals, who are in the community and have psychiatric or developmental disabilities. And I try to advocate for whatever it is that they're seeking, whether it's to be released from confinement or the quality of their care, the kind of treatment they're getting. Many people are trying to get into an appropriate residence and get the right kinds of services and treatment. And in this environment that we're in right now, all of those things come into play because there's a lack of housing. Where do those people go? They don't want to keep them in psychiatric hospitals or even in medical hospitals, and they want to get them out as soon as possible. If there's no housing, where do they go? They're not necessarily the best candidates for treatment because so many people have serious comorbidities, and add to that often people with developmental disabilities can't express themselves. And in the hospital, they no longer have access to, at least in New York at the moment, we hope that will change with more advocacy. They don't have access to their caregivers and loved ones when they're, truly in extremis. And all of this creates an environment for people with disabilities that is in many ways just so unequal to what everybody else, as awful as their experiences are for people who don't have disabilities. It's compounded tremendously for those people who really are struggling in their everyday lives, every moment of their lives. So the advocacy has been tremendous in New York, not just my organization, but all of the disability rights organizations. And I know across the state, across the country, they're all doing the same thing. What we're experiencing in New York now is that the state agencies have been slow to come up to what we are hoping in terms of their response to the difficulties we're seeing among our population. And we're starting to see some response now. It's taken a long time for everybody to coordinate between the medical organizations, the care organizations, the rights organizations, and then the state agencies. And we're now, 3 weeks into the serious pandemic crisis situation, and everybody is beginning to talk to each other. And I suppose that was because we were all sort of getting the feel of what our concerns were and what our priorities were. But I think from the disability rights advocates, those with disabilities are still very low on the priority list. Those are the concerns I'm dealing with on a daily basis.
I mean, it's sort of scary stuff. I mean, we're facing an epidemic, a pandemic, likes of which we haven't really experienced in our generation, and now there's this additional component. I mean, there's one nuance after another, I think, is coming up as we go further. Dr. M, what are you guys doing there in Austin? How's your preparation coming? Turn your mic on. Turn your mic on. There we go. We haven't done studio work in a long time. You can see that.
Really long time, and I'm still the baby. This is baby. This kind of Zoom. We are very much in a hurry up and wait situation here. We got a big rush saying that our surge was going to start actually right around now. And we've, in this town, done a super good job with the social distancing. So we've actually flattened our curve, which is fantastic. So that now they're pushing those dates back a little bit, but I don't work directly in the hospital since I do so much international work, but my husband's actually a physician and he does work in the hospital. And we've got several COVID patients, but by no means is it overwhelming our system at all. We're, Lisa, very much in your situation of how do different groups of care providers communicate with each other. You have the state and the city who've come in and they have one sort of set way of doing things. And then in our community, private practice is the major component of most healthcare. And so that group of people operates in a very different way. And figure out who's going to have the right personal protective equipment and who's going to take care of what sets of patients. It's been, I think, a communication challenge in every direction. It has.
We're lucky in that although we don't all communicate with the same people all the time, the core group of people have been terrific about reaching out rather aggressively and making contact with the medical groups, places like Northwell and NYU Langone. I mean, the really big hospital and Mount Sinai as well. And they've been reaching out to us, and the questions they're asking are really incredibly serious. I mean, when the hospitals reach out to you and say, how do we go about, in essence, circumventing the laws that are in place to protect people with disabilities at their end of life? so that they are not treated less than people who don't have those disabilities. We have in New York laws that are in place that you must follow in order to ensure that the person who is, for whom an end-of-life decision is being made meets end-of-life medical criteria. And it's a pretty high bar. And it's very difficult for the doctors to make those kinds of decisions and to get a capacity determination for that individual that they can't express themselves or make decisions on themselves in such a crisis environment. They don't have those resources. And so early last week, they were reaching out to us and saying, are there ways that we can shorten that process? And until the governor says you can circumvent the laws, how do you do that? You just can't. So it's a quandary for everybody. And add to that the problem of how you allocate ventilators.
Right.
We in New York, and I believe in Massachusetts as well, and you probably have it in Austin, I'm sure we have it in every state, there is some kind of a pandemic plan that speaks specifically to the ventilator allocation. And it arose after the SARS epidemics.
We have a quandary too, and it is all about communication. And the communication right now is from our sponsors. So we are going to take a quick commercial break. We'll be right back with the Dr. Joe Show. We'll be right back. So while ATD is doing their commercials, we're still recording and doing this. Are we live on Facebook yet?
Nope.
We're getting blocked for some
Yeah.
reason. I don't know what's going on.
Was it the same last night? I wonder whether they just don't want to talk about Corona. You know?
No, I think there's something more at play. Like Zuckerberg's preparing for like a subscription model or something that he hasn't launched yet.
Okay.
And he's just blocking us for it right now. But you're the host right now because I'm having a substantial windstorm here. It knocked me out. I thought the whole show was down for like 3 minutes.
If you punt it back to me, I might be able to do it live on YouTube.
I'm the host?
Yeah.
All right, so yeah, go into participants below. I punted it to Tom just to get it out of here because I thought I actually took the whole show down. My whole house went black. My computer glitched out. Did you see me sitting in there in the dark?
I did.
I thought, what's he doing now? That
No,
guy?
the whole play.
God, he's just, and I always thought it was me.
Jimmy's in the background going, Dad. So
Yeah.
it was chaos.
No, the kids make fun of me because years ago when the lights went out in our house, I made the announcement. I said, the lights are out, and everybody started laughing because they already knew that. So
Yeah.
I'm not really the host, right? Tom is the host, right? Because I see a little red dot next to him. Are we listening to ATD?
The red dot means I'm recording.
How did you know to go to the commercial?
Because I'm looking at the chat.
Ben posted in chat.
Oh, did he do a private chat with you?
Well, he just sent a thing saying,
Sent to everyone.
Oh, we're
But
back live.
Are you listening to him? Are you listening? Can you hear Ben Nipotent to tell us when we're going back on the air?
I'm looking at my chat.
We're live We're live at this very moment, Dr. Joe.
But we're back on ATD. Hello, ATD. This is one of the things about Zoom.
You're watching the chat box in the screen here, right? With the Zoom, he just, Ben's communicating through text to us, right?
Hi, Ben. We're back live.
Remote, right?
We're
we're able to do remotely.
We're back live now, and this is part of what we're talking about. Is not to be flippant. How do we keep people alive?
Yeah.
That's really the issue. So, Dr. Ann, have you been in a position, not necessarily with this particular pandemic, but in general, where as a physician, you have to make some choices. And if your husband is around and wants to hop on, more than welcome, more than welcome. Don't forget to turn your mic on.
You're going to have to tell me that every time.
I will.
I think that whenever you're dealing with somebody whose quality of life would be compromised at a level that everybody has to take a little care to think about what the next step is, or if their quality of life would be compromised to not take valiant efforts, then the time just comes to be thoughtful about that. So yeah, I've seen that in places where I didn't speak the same language as people, and certainly in the hospital as well. It is difficult because you have to very quickly take a look at what you think the other person's value system is and judgment system. It's not really about what I think should happen necessarily, but then combine that with the fact that as a physician, I might have a little better medical knowledge about what the next thing is that's going to happen. And so sometimes that's terrible news to bring to people, but a lot of times I find that people are very comforted if you're really straightforward with them about what the next few steps may be. I think what's so crazy about this particular coronavirus is that people already know what could happen to them because we're literally watching this epidemic happen right in front of our eyes. And everybody knows that they could be one of the 5% of people that end up on a ventilator. So that puts a different spin on the level of anxiety around the whole country, that we're all being thrown into this pandemic, into this situation. I think that's where a lot of this anxiety comes from.
Yeah. And again, as a physician, it is, I want people to sort of understand what this really means, because it has never really been our job to decide who lives and who dies. Our first rule is do no harm. But I think, what Lisa is talking about is what happens when we're in a position where we do have limited resources. And this is something that there is no clean answer to. And for our listening audience, I would welcome your thoughts on this. But how are we meant to make a decision? And the reason I wanted, the counselor here is to say, how do we protect those people who may be the most vulnerable? Not just to coronavirus and COVID, but in general, a group of people in our population who many people just turn their backs on because they don't think they're valuable. They think, because remember, this is all I am. Some people don't think people's I am is valuable. We've had this not just in, psychiatric conditions, mental health conditions, addiction conditions. We've had it in our world for a long time, one race against another, one religion against another. And that's why I really wanted to talk about this, because the I am is saying, no, we're one group. We're one group. It's called humanity. But the reality is, what happens when there's just not enough to go around? It's a terrifying thought. So Lisa, where are you at with this? How do you advocate, and what happens when you get pushback?
Well, luckily, we're not getting a lot of pushback, active pushback. Nobody's saying we're not going to treat your population. But we do have this ventilator allocation guideline, which has implicit bias because it sets it up so that the people, they sort of triage. A clinician looks first and says, this person has whatever illnesses, underlying illnesses, and some people won't even make it to the list of people who might be eligible for ventilator support. Some people will, but are maybe marginal and may be on the list and may get a ventilator, but then at certain points over a period of 2 to 5 days, they're reassessed. And if you don't make progress fast enough, you're taken off the ventilator likely, because somebody else will do better. Because the goal becomes not do no harm, but how many lives can we save? And it's inevitable when you're trying to save as many lives as possible that choices have to be made. And I mean, this is a Herculean task I admire and sympathize with. I don't know how to empathize, because I can't imagine what it's like to be a doctor in a situation of having to choose like that, because most doctors in our generation have never been in that kind of situation. But to get back to that implicit bias, you bring your own human feelings and maybe what you've been brought up with or what you've been exposed to how you view somebody with disabilities. And then the reality is that most people with disabilities, they range from not very disabled to very, very disabled, both physically and mentally. So they can't communicate. They have many comorbidities. And many of those comorbidities are on the list of exclusionary criteria. So they might be off the list for ventilator support before they even make it to the hospital. They have and what happens to those people? And even those people who maybe are showing some signs but are getting turned away from the hospital, which is happening a lot for people in group homes. They go back to their group homes. People are dying there. And they can't be with their family members because they've now been cut off from visitation. They have, if they're lucky, they have caregivers who are there on a daily basis and know them, so they have that kind of comfort. But what about the people who do get admitted to the hospital, but there's no visitation, certainly not in ICU, but no longer even in the hospital beds? So now those people are extremely ill, can't communicate easily, so they can't even say how badly they feel, and they're dying alone. It's heartbreaking. And so what are we doing? We're trying to ask the government to relax some of the visitation rules so that people who are truly disabled have somebody to be with them who can comfort them. And we're trying to make sure that people don't just get sent home from the hospitals, but it's happening by the thousands now. On Long Island, where I think we've had something like 33,000 people, or it's about 66,000 people have been tested, and about half of them have tested positive.
Wow.
And of the group homes, many people now have been exposed, both the caregivers and the residents. And then there's this other part of it, which is there's not enough protection, personal protection, masks, gloves, gowns. People are scrounging and they're sort of on their own because the government just doesn't have enough to go around, and they give it to the medical personnel first, rightly so. But it leaves everybody else tremendously vulnerable. So there's no easy answer. The best we can do is just keep pushing and pushing and pushing, meeting daily. We're all in our own homes. And the lawyers I work with are doing court hearings when they have to, remotely. Doctors are doing telemedicine in order to determine capacity and all of those kinds of things. But it's a faulty system at best. It will stand the test of time. And if we ever have to go through something like this again, we'll certainly be a lot better prepared, and I hope we'll learn from it. But it's been a really slow process, and I hope that the pandemic dies down, at least this first wave, before we even have it all perfected, because that would be so much better than, having it perfected and knowing that we lost so many lives in the meantime. No real answer, is there, Joe?
No, I wish we could come up with one here, but the only, again, not to be flip, the only answer that I have for us right now is to take a pause and think about it. So, Beneficent, let's take the next commercial break so we can give some thought to what's going on here. We'll be right back with the Dr. Joe Show. So, are we off air, I assume, Mark?
We're off air, but we're recording.
You're off, right. So, I know that this is dark, but we and we may not come up with solutions, but what I hope we do is to let the listening audience understand this aspect of the dilemma, and they then, you know, can have some input into it. You know, we're not going to be asking for phone calls because we can't really do that, you know, very efficiently. Can we? Right? We can't really do it.
Not really, no.
No, we don't want to do that. But we're going to have we're going to be back in 20 seconds. And so, Anne, I'm going to maybe go right to you and ask you, you know, what is going on there? What are you learning from the preparations that have happened in New York and other states, right? And how would we necessarily address this so that we can allocate resources? 3.
You're mute, Mark. We're back.
It's going, Mark. Say it again.
We're back with the Dr. Joe Show, talking about what everybody's talking about, but a little bit of a different spin tonight, folks. So fasten your seatbelts and turn up your radios and listen in on some of the goodness that we're trying to spread out tonight.
Right. So we've been talking about some pretty dark stuff, as Mark is saying. Dr. Ann, what is going on? What are you learning from all of our stuff that's happening out here on the different coasts? And don't forget to turn off your microphone. Oh no, actually turn it on before you, there you go. Almost. Yay! So really, I mean, we're learning so much, unfortunately, at the cost of a lot of lives. What are you guys doing there in Texas? You say, you know, you're sitting there, you know, getting ready and waiting. What's the prep? What's going on?
Well, you know, my husband and I were talking about it. It sort of feels like we're in a zombie movie. I mean, it's beautiful outside. The birds are still singing. It's incredibly quiet everywhere we go. There are patients in the hospital who are sick, but everybody else is just sort of hunkering down, trying to stay socially distanced. Don't go to HEB. We're all wearing face masks at HEB right now, which that is so weird. So a large part for me is just what it's like to be a person with a acute awareness of how horrible it could be from a medical perspective. And the doctors who are still in the hospitals are just petrified that they could actually fall prey to this illness, because, you know, some estimates of the mortality rate for physicians that are older who are taking care of this population is 20%, which is incredibly high. So then you've got the whole decision about, what are you going to do? Are you going to step in there and do your job? And the part about whether or not there's enough personal protective equipment is sort of a social contract with if you are providing care through an institution to a population that's neglected in one way or another, are you bound to do that if you can't be protected yourself? And then that puts you and your family at risk and the people all around you. So that's a question that comes up that's a lot, as the same sort of ethical dilemma as the question of how do you choose who you care for? That's another huge ethical dilemma. And then coming home and dealing with your family and changes of income and all the other things that are going along with it. It's a big issue. In another thing that I'm seeing personally that's kind of what we're talking about is my work is primarily international, and I work with a lot of communities that don't have hospitals to go to. And there's not this beautiful gleaming white hospital with a great operating room or any ventilators at all. And I've seen people on ventilators in developing nations that it would just chill you to your bones to see how that gets handled under those circumstances, where people just have limited opportunity to have education and advanced knowledge about this. And a lot of the populations that we're speaking to, they're just waiting for this to come, and they know that they're just going to lose 20% of their population. It's just sort of a given. And that's a whole other bizarre thing to even consider. It's just surreal for us, although, Lisa, it's got to be the absolute deepest reality for you to be living in this situation. And we're sort of observers still, but very much grappling with the same ethical issues.
Well, I think inevitably it'll come to you in one form or another. I hope that you don't have to make choices about who goes on a ventilator. I know in New York of at least one hospital organization, and now, you know, we're talking about many, many hospitals now because they're all joined together under one roof or under several roofs. And they have put out an allocation guideline that follows the 2015 guideline that I'm talking about, but they're dealing with the possibility, and probably at this point they're enacting the guidance because they have no choice. So what does that really mean for our population? Well, the guidelines start out by saying, we do not discriminate in any way. Everybody gets the same kind of care, but here's the way we're going to triage it. And the minute you triage it, the implicit bias is against people who have other illnesses because they are the weakest and they're the least likely to survive. And that not only touches people with mental and physical disabilities, but people of color. And we're seeing, certainly on Long Island and in New York City, without a doubt, people of color are testing positive, and of course, many going the way of illness and possible death because they're more ill.
But also want to mention that that's the virus. It's not doctors making that decision. The virus preys on people who are already sick. The virus preys on people of color. New discovery. That's the discovery of the last 48 hours. The virus goes after the elderly. So it's not, I hate to have it be only that doctors are having to make that sort of stratification. I think the virus did it for us already.
You're absolutely right. And I like the idea of taking away some of that, you know, I don't want to call it fault or blame, but that's a little bit how it feels. And that's certainly not what I mean. When I'm talking about it, I'm talking about if you do those stratifications and you ignore whether a person has a disability, whether they have, whether they're of color or whatever their background, whether they're elderly, it's still more likely that those people are going to be triaged as less likely to get the same ventilator support. And they're going to be lower on the list because they're the people who have more comorbidities. And that's just the reality of triaging. So when I talk about the implicit bias, and I'm not even factoring in the bias that every one of us brings, as much as I would like to think that everybody will take the I am approach, Dr. Joe, at some point in their lives, this is not the best time for it because people fall back on the biases and their fears play in so much, just as Dr. Ann was just talking about. Fear comes into the decisions and the equations that we all make, whether we're doctors or caregivers or whatever we do.
Yes, absolutely. But it is our amazing ability to recognize that that's important. And recognition is a thinking function, not a feeling function. When we can recognize these biases, we can do something about it. And we have avoided politics and things like that in the Dr. Joe Show purposely, because it's still an I am. Mm-hmm. But my concern is that this is exposing once again this part of who we also are as humans. You know, we can be really, really good at reminding somebody of their value, but we're also really good at putting people down. We're really good at separating people, at saying you're not worthy enough. And that's my concern, is that this virus will push us in that direction, as opposed to saying, how do we work this out? How do we figure this out medically, ethically, morally? How do we do it together? You know, our first rule as physicians is do no harm. But this puts us in a position to do the least amount of harm, right? That's what this pandemic is making us do. It's saying, okay, I am being put in a position where I'm going to have to choose, and we have these point systems, that, as you say, are somewhat arbitrary. But we were having this discussion the other day. Let's say you've got a person who has diabetes, but they've got 4 kids, and they can help other people, but they get COVID. Are they now pushed down the list of triage because they've got diabetes? What about the person who has no kids, still, is living in a community, but they don't have another family to take care of? Do they then, because they don't have diabetes, do they get pushed up the list? See what I'm saying? It's not simple. So,
You're asking to value a life, right?
that's the thing. And how do we really do that? How can we do that? Mark, what do you think about this?
I think it's virtually impossible, and to have that responsibility is not it's not sustainable for any one person to be able to make those decisions. When people start, and I don't really know where we are with the resources. Is there no way that there's going to be enough ventilators for the amount of people that are coming in? Is that clear? Like Italy put a tag on: if you're 80 years old or older, we're sorry, you've had a good life, don't come, you're not persona non grata at the hospital. I mean, are we at a point in the United States that we don't? Because I know there's been an effort for companies to start making ventilators, and there's been a massive effort to do that. Are we at risk? I'll ask the guests, are we at risk for being outnumbered and having to make these ridiculously unfair choices?
Anne, what do you think?
I think that one of the reasons that there has been such an intense race, both in the public and particularly in the private sector — I'm so impressed with the private sector — is that we just won't accept that.
Right.
No one's going to say that you can't come in here because you're 80 years old. And I think that it may be unspoken. We need ventilators. People don't say, well, we need ventilators because we're not willing as a society to place a lower value on one person's life over another. But that is what we're saying when we say we need ventilators. And so I think instead of spending a whole lot of time making those decisions or creating those criterion, I know they have been created. That's the job of people in the ridiculously horrible position to have to do that. But it's wise to do it before you're in the emergency. But we've had vastly more people saying, how can we fix this? My brother-in-law made an external ventilator, a breathing machine that you just strap around your waist, and it works really well. And he did it in his garage. I mean, people are responding in that way, in ways of ingenuity. And we've got here in Austin, there's many entrepreneurs who are working on how to put together ventilators, how to make them out of pieces that we already have. So I think as a society, we've sort of refused to join the conversation of who doesn't get a ventilator. And instead, everyone's jumping on the bandwagon of how can we make this work?
And the reality is that we are not yet there. That one medical organization put out that guidance is their way of saying we're recognizing the realities and we're prepared for it, which I think is the right thing to do. But I think Dr. Ann is right that as a society, we've never accepted less than the very best that we could do. And this is an opportunity to really show that. And I hope that we succeed. I think in social distancing, I know that in New York, they're starting to say that they're seeing a kind of leveling out. And that may be society's way of responding, as Dr. Ann is saying, and making sure that we don't get to that point. And if we have anything to say about it, I think that's absolutely where we're going to be. But I think social distancing has been a brilliant and quite successful way of keeping it from going any further. I have to say, in Long Island, though, I had to go to the grocery store, and it was shocking to me how many people were walking around without a mask and without gloves at this point. And I know that they're going home with their fruit in their boxes and they're not cleaning them, but it's so easy to do. Why wouldn't you? And yet people don't. So
They don't know. They don't know. I think there's a lack of information out there as well. And where the information is coming from, unfortunately, a lot of it is from the politicians who are afraid to upset a certain contingency. So they're not taking the aggressive measures that they should. And people are still presently blowing off what the doctors are saying.
That may be true, but you know, I am not a politician, but a physician, but I still don't want to annoy my sponsors. So what I'm going to do, we're going to take our last commercial break. We will be right back with this remarkable discussion about really things about coronavirus that we need to be thinking about. We'll be right back with the Dr. Joe Show. So this is a great discussion, but how do we now pivot it, turn it, so that we can give something positive to our listeners? Because
I liked how Ann was saying that the private sector is really stepping up to partner with the healthcare and the needs, and the fact that, you know, we don't have enough, but as a nation, we're just not willing to accept that.
Right, and that's the message that Ann is saying and Lisa's saying, and that's what we need to get out there. Is, you know, we get to influence people. You know, the second rule of the IM, you control no one.
He's coming back quickly. Did you see that?
Yeah, we're waiting for you.
He counts me in at 3, 2, 1, I think. But I'm not muted this time, right?
No.
3, 2. And we're back with the Dr. Joe Show, talking about what we're talking about, what everybody's talking about. How else could we talk about anything but what we're talking about?
So what are we talking about?
Triage.
Tom?
Triage.
Triage. Tom, what do you think about this? I mean, we're talking about stuff that, you know, you're I'm going to just point out that you're the youngest one in the group right now.
Mm-hmm.
How does this discussion sit with you?
I have a more pragmatic brain, so like I figured this would be coming. I don't blame any doctors for any decisions they make. That's all I'll say. That's all I'll say.
Okay.
I mean, we can't blame them. I mean, they're put in an impossible situation, and they're just doing the best that they can, right? Isn't that?
Yeah, and again, it's not about blame, but we all have responsibility. There's a difference between responsibility and blame, right? Responsibility is empowering, and we all can take some. Go ahead, Ann.
I was just going to say that I think conversations like this, where you do get a chance to say, to make it not be about blame, this is amazingly the third interview that I've done. And I was on another interview, and the host brought up, aren't you frustrated at those college kids who are all still going out on spring break and all the people partying? And, you know, yes, but really not, because they're just like the people in the grocery store who weren't appropriately educated enough to where they went, oh my gosh, I don't want this.
Right.
And came home. So here's yet another example that I think is incredibly powerful. We were talking about that. I'm in Texas, so in Austin, so the university's here in this town. And my organization, One Good Turn, is already this morning, we got contacted by a bunch of college kids who wanted to make a difference. They didn't want to be seen as the college kids who are out there partying all the time. They started a Facebook group, and they picked the population that they want to reach out to, which is the elderly people. They're working on messaging toward that. They're sending out GroupMe texts everywhere. They've got these cool ideas about making postcards with something that you write on the front of it saying, hi, I'm thinking about you, and on the back, a little health tip. And they are putting this together because they don't want to be part of the problem. They want to be part of the solution. And this is actually a great opportunity for so many people. It's the search for relevancy. We all want to be relevant. We all want to be part of the solution under this circumstance. And I've seen it over and over and over again with private people and kids and this wonderful college group that literally got started this morning. And it's a great opportunity for people to recognize that we can be part of the solution and that we can all do that together. And sometimes it takes something as dramatic as a pandemic for us to realize that we can be part of the solution. And I hope that then having people sharing that experience, that it will affect us long beyond this pandemic in recognizing that we can actually all act together as a society to stave something like this off.
Right. While we got you, you want to just tell folks about One Good Turn and then what you've created?
Oh, sure. One Good Turn is a global nonprofit. It's a medical nonprofit, and we provide practical medical education and culturally sensitive medical care to neglected communities all over the world. And so my job is to go to a community where there are care providers already taking care of everybody there and just make sure that they have the appropriate tools to do the best job they can. And that may be learning about how to do a good physical exam or understanding more about the sorts of medicines that they have available to them and what medicine matches what illness, teaching people about subjective versus objective decision making so that they learn that it's not just about what people are feeling, but also about some of the physical or the physical findings that we have with, say, a pneumonia or asthma. And so that's what we do. And coronavirus happens to have been the way that we work, which is low amount, high frequency learning, works really, really well for coronavirus and for public education. So we really pivoted to provide the same type of education that we do internationally to right here in America. And it's worked out really well. So that's why I happen to know so much about coronavirus, because I've needed to learn about it a lot so that I can teach people around me and teach the people in other countries as well.
Yeah, and I'm fortunate enough to be on that mailing list now. So I get these remarkable updates every day that is looking at really legitimate sources. So it's either WHO or PubMed or other journal articles. How can people get on your mailing list so that they can get those things?
Oh, thanks. Just go to www.onegoodturn.org, O-R-G, and you can very easily sign up there. We're also on Facebook. I think that's the number one Good Turn, and then Instagram, and it's just one.god.turn. You can
it's a really good source because, you know, there's a lot of news out there that's sort of sensational and a lot of stuff that you're not really sure about, but they really curate sources that I believe in, and I've also learned a lot. I go to those links every day, and I'm just seeing what's being published. It's really fascinating in the literature how much is being published and how quickly papers are being pushed through the peer review process, which has its pluses and minuses, because there may be stuff that's coming out even in peer review articles that later on will say, nah, maybe that wasn't quite the case.
Yeah.
But it is definitely worth checking out.
Well, thank you.
It's worth checking out. Lisa, want to add something?
It sounds like a wonderful organization, and I'm going to get on that list as well. I would also like to just point people to their own state government's websites, which have very basic information, but it comes from the CDC, it comes from the WHO, and it may not be articles and more medical information, but it is very important information about how to keep your hands clean, how to social distance, and the ways you can get food if you need it. Really the very basic everyday things that you need to survive. So it's a very good resource, and people should reach out to that as well on a daily basis. Things change every day.
Right. And that's the part that's fluid about it is things are changing. But I think what this coronavirus has done is equalize us. And I think that's a good thing for us to remember that we really are in this together. And if we're faced with a position where we have to choose who lives or who dies, I don't want to have to be in that position. I don't want us to have that limited resource where we've got to say, you get it and you don't. We don't need to do that. Now, you know, Dr. Ann, you work in countries where they have limited resources to begin with. We are in a privileged position here in the United States, but we also have to become leaders. What we do now, how we make these decisions, is going to send a very important message to the rest of the world about how we treat each other as human beings, how we value each other. And yeah, maybe it's idealistic. I don't think so. I think that this is that pivot moment in our humanity. Say, who do we really want to be? We can go right back. We can go right back to tribalism. Easy to do. Really easy for us to say, you know, you don't quite cut it. And so we're going to cut you off. And there's going to be an elite group that would do that. But boy, I'm not there, man. That's not what I want to do. How do we help everybody? And social distancing is one way to do it. It's not the same as emotional distancing. It's really important people understand that. Just because we're following the rule to keep ourselves a little bit apart doesn't mean we have to do that emotionally. We need to be connected emotionally. And that's part of what is I think, so amazing about what I'm seeing in our technology for those of us who have it. I will be perfectly honest. Lisa and I and some others, we had a Zoom dinner on Saturday. We had a couple from Maine, Long Island, and 2 parts of Massachusetts. It was delightful. For my wife's birthday last week, I'm not going to tell you how old she is, but I bought pizza for people in 2 parts of California, in multiple parts of Massachusetts, so that they could all be in a surprise pizza party for Carol. She didn't know what was happening. Say, come on into the living room, sweetheart. And she comes in, and there's our pizza, and there are everybody on the TV sing her happy birthday. This is what we can do with each other right now, folks. Reach out to somebody that you might not have spoken to in a while, just to find out how they're doing, just to see if they're okay. Just do something small like that. Remember, small changes can have big effects. With that in mind, 2 rules of the IM. Small changes have big effects. Lisa, what small change can you recommend to our folks? And then I'm going to come to you, Ann. What small change can you recommend to our folks that can have a big effect?
I would recommend just trying to think of everybody as the same as they are, and look at them, whether they have, especially if they have a disability, try to look at them and treat them in the same way that they would want to be treated.
Yeah, and I'd say it's an IM. It's a unique ability, not a disability. It's a unique ability. They are remarkable people. And what about you? What small change? Don't forget to, there you go.
Yeah, there's my small change. Make eye contact with people. We all have masks on. We're all a little bit further away from each other than we normally are. Make really good eye contact with people. They'll be surprised. You'll be surprised, and you'll have a connected moment, even though we've got our mouths all covered up. I think that's a great thing to do.
And then the last thing, we control no one, we influence everyone. I'm going to start with you, Ann, and then go to you, Lisa. What kind of influence are you hoping to be? Ann, what kind of influence are you hoping to be?
I hope that people can understand that you can share knowledge without being judgmental.
And Lisa, how about you?
I hope to just be able to communicate with as many people as possible, to to represent the people that I am most worried about now. And just to add to Anne's mask, I make sure that when I'm wearing my mask and I'm out in the supermarket, that I say hello to everybody that I meet. Regardless of the response I get, I want them to know that I'm smiling behind my mask.
Thank you. Folks, great show. We're gonna do this together. Everyone's at an IM. Let's just respect that about each other. We'll see you next week. Bye, guys.
Thank you, Joe.
Thank you so much. It was great.
Good.
Thank you.
So we may be off the air, but we're still on. So I just want to thank you guys because it's, we tackled a really tough subject tonight.